Talking on meniscal injuries in cricketers, we all know cricket is always a glamorous sport, and it's called a religion in India. And of course, everything comes with the baggage. So does cricket, and the baggage is injuries. We have seen of late a lot of cricketers have their knee issues, have their knee injuries, have a setback. Of the meniscus, lateral meniscus injury occurs while playing a twisting sport or a twisting action in cricket, whereas your medial meniscus injury is basically an overload injury. Batsmen, while taking a quick run, can also sustain their injury. So let's see how and what are the tear patterns one could involve in cricket. We know of Andrew Flintoff and Usman going out of sport because of their meniscus injuries. It's very important that we understand our Indian pattern of injuries. There was a study which was done in about 363 athletes, which found that ACL tears were the most commonly injured ligament in the knee joint. Secondary was the meniscus. So we have about 78% meniscus injury rates in these active sportsmen. And among the meniscus, the medial meniscus was found to have more rate of injury than the lateral meniscus. I will tell you about that in detail later. The overall injury rate was 79%, but this is astonishing. Only 40% of these guys who have had or sustained meniscus injury could actively get back to sports. And among them, the people who have been treated surgically are the ones who have been having a quicker and a better recovery. It's very important that we understand the meniscal anatomy. We all know it's a crescent-shaped structure, it's a wedge-shaped semilunar structure. There's the medial meniscus, the lateral meniscus, and this is made out of fibrocartilaginous collagens, the type 1 collagens. What is important to know are these insertion ligaments. These meniscus are free-floating ligaments, and they need to be inserted or probably inserted to the bone. And how is it done? It's done by these insertion ligaments, which are in the front, called the anterior insertion ligament, posterior insertion ligament of the root, and of course, there are something called the capsulomeniscal junction, which is nothing else but a condensation of your medial collateral ligament, which forms as the deep MCL, which attaches the meniscus to the capsule of the medial side. Medial meniscus moves about 2 to 5 millimeters through the full range of movement, whereas your lateral meniscus, because it's devoid of capsule in the posterolateral aspect, it moves about 1 centimeter. So if a person sustains a twisting injury, it's more of a medial meniscus which would be at risk than the lateral meniscus, because the extrusion of a lateral meniscus is much more than a medial meniscus. Histology, this is very important. Can you just see the structure? You see this is the histological structure of a meniscus, and we see that it is nothing else but, imagine a tape of fibers laid in the circumferential manner. So it's formed out of circumferential fibers. So if you have an injury in the line of the fibers, which is called a circumferential tear, that would be more of a stable injury, and it would have less effect on the meniscus in the injury. Whereas if you cut the fibers transect it in a radial manner, what would happen? The entire of the meniscus would get defunctional. So I think I'm clear. A circumferential or a tear along the lines of the fibers is more stable, whereas the tear which transects these fibers are unstable. We all know, we all talk about the vascularity of meniscus. Meniscus is devoid of blood supply. So that's the reason meniscus doesn't heal well and doesn't heal quickly. We see here the histology, only the lateral third or the outer third portion, the 30% of your peripheral meniscus is richly vascular, which is called a red zone. The middle third is partially vascular, which is called the red-white zone, and the inner third is called as the white zone. So when you have an injury in the inner third, these are the injuries which do not heal and probably which may not be amenable for repair as well. We see here the vascularity is what I spoke about. Why is meniscus so important? It is called the lighthouse of the knee joint. That's because it reduces the contact stresses of the two cartilage. It spreads the load, acts like a shock absorber, gives you stability, lubrication, proprioception, and of course nutrition. It transfers the load. Imagine a person standing, running, or lunging. It takes away the stress of the cartilage and it increases the contact surface area. When you compress the meniscus, actually it spreads and it increases the surface area, and this is what protects or cushions the cartilage, hence preventing arthritis. When you have a loss of the meniscus, increased contact stresses. There is 200% increased contact stresses. Typically when you walk, when you lunge, and when you climb stairs, and when you squat, there is 200% more stresses on your cartilage. Hence, the cartilage is more prone for a wear and tear without a meniscus than the latter. It also gives you a stability. You've seen, I told you, meniscus is like a semilunar structure. It is a dish-shaped structure, so it gives you an anterior posterior and a rotating stability. So if an individual has an ACL tear, and if simultaneously he has a root tear of your meniscus, these knees are highly pivoting, and they are more prone for repeated injuries. What are the factors which affects or increases the meniscus injury risk? Condition of the ground, lack of warm-up, position of the player in the field, age of the patient, experience, low nutrition status, contact injuries, unsupervised players. We all know this. What is also important, we have seen that the player in the second half of the day, because of the fatigue and lack of concentration, is more prone for these injuries. Lack of ground watering and softening of the ground, previous injuries of the knee joint, competitive games without training, anabolic steroids, and of course absence of sports for more than a month puts a patient at risk of his knee injuries. What are the variables here in knee injuries? The environment in which the player is playing, the ground condition, the hardness of the ground, dryness, grass cover, and of course the root density. How much of your grass is laid down. One mechanism which is very, very popular among fielders, this is what the coaches teach the patients, teach the athletes, is sliding stop method. Of course, it's a wonderful technique of stopping the ball in the boundaries, but this is at a maximum risk of having your meniscus tear, typically the medial meniscus tear, and this has to be done or performed correctly. If an inappropriate performance of this kind of an act would lead on to a meniscus tear or a meniscus injury. Meniscus can tear in various patterns. Let's just look at it. Look at this. I spoke about circumferential tear, a radial tear. You can have a small flap, which is called a flap tear, a bucket handle tear, or a horizontal and a complex tear. Let's look at this. Look at this arthroscopic picture. The patient has a tear along the line of the fibers of the meniscus, and this is called the circumferential tear. These are the tears which are stable. I wouldn't really be very bothered about repairing these tears, and these are the tears. You see the vascularity there as well. It's in the red zone, so this is a tear which is bound to heal. On the contrary, what is this? This is kind of a radial tear. You see the transection of the meniscus. It is transected parallel or perpendicular to the line of the fibers, and these are notorious tears which are having a low capacity to heal. When you open up a book, or imagine a sandwich, this kind of a tear pattern is called a horizontal cleavage kind of a tear, or a fish mouth pattern tear. You see here, I'm opening up this menisci, and there's a pocket of tear inside, and this is called the horizontal cleavage type of a tear. Of course, this is a stable tear, but can be painful to the patient. A flap tear, a small flap dangling around, these tears can cause mechanical blocking, and these patients are the ones who would come and tell you, I have a nagging pain, a discomfort, a kind of a locking sensation, I'm not comfortable playing my sport. Of course, this would cause a true locking. Entire meniscus rooted out, bucketed into your knee joint, into the intercondylar notch, which wouldn't let your knee to extend. And these are called the locked knees or the locked meniscus, typically with the bucket handle meniscus tear. Complex tears, they can have, a patient can come with a multiple injury pattern, can have a high impact injuries, and these are the patients who would land up with kind of a complex tear, which is a combination of various tear patterns. What is important, what is making news nowadays is something called the ramp lesion. We all need to know what exactly is the ramp lesion, and this cannot be missed out. Sometimes the patient who have had an ACL tear complain of the posterior medial knee pain, and that's because of the ramp lesion. The ramp lesion is nothing else but a detachment of your capsule from the posterior medial corner of the knee joint. You see this? This is the posterior capsule, and this is the medial meniscus. This is a patient who sustained an ACL injury. He has got a detachment of his posterior medial capsule from the menisci, and this is seen in about 8 to 14% of your ACL injuries. So ramp lesion cannot be missed out. Decision making for me as a surgeon, the current I think we have discussed more and more over the last 2 days regarding the conservative management, the treatment guidelines. I would give you the surgeon's prospect: a complete vertical or a longitudinal tear of more than 1 centimeter, tear which is unstable, tear which is in the periphery within 3 to 4 millimeters from the junction, and of course which is associated with other injuries like an ACL tear, I would go ahead and repair. Failure percentage of meniscus repairs are 19%, more on the medial meniscus than on the lateral meniscus. Factors which affect the healing of these meniscus are concomitant ACL injuries apparently do better, peripheral tears heal better, lateral tears heal well. This is a cricketer, 40-year-old cricketer in his last phase of his life of cricketing sport, comes to me with a neglected meniscus tear in the white zone. I wouldn't want to salvage this. What I would do, he's got his last lap of his sporting career. I would take a risk. I would counsel him, and I would rather do a meniscectomy, a partial meniscectomy. What I've done here is remove the blocking portion of that, did a partial meniscectomy, retained the functional 1/3 of the meniscus, and I've put him back to sport in 3 weeks' time. On the contrary, a 19-year-old boy with an ACL tear and a bucketed meniscus tear from the red-white zone, the entire meniscus is rooted out into the intercondylar notch. I wouldn't have an heart to remove this meniscus. It's so juicy. Look at that. There's so much of vascularity. Removing this meniscus would put him at a risk of arthritis in another 3 to 5 years' time, which one wouldn't want. So I would counsel him for a delayed return to sport. I would say you're going to get back to sports in about 9 months' time. Have patience. Put him into some form of physical therapy, maintain his endurance, but impact sports, of course, a competitive sport would be later stage of his life. In about 9 months' time, how would I treat this meniscus? Of course, one would go ahead and repair this meniscus. There are various ways of repairing a meniscus. I would put the meniscus back. There are 3 techniques. One is the outside in, where you put needles from outside to inside the knee joint and stitch it. Inside out, where you put the needles from inside the knee joint and pull it out like a suture. And then all inside devices are the devices which are handy. Of course, it comes with a cost, but they are quick and nice devices. So these kind of tears, you need to use a combination of all these repair types. You need to have a good steady repair. This is an inside out repair technique, and you need to have a good steady repair for the early return to sports. Meniscus root tears, as I discussed, any tear within the root anchor of the meniscus in the posterior horn up to 1 centimeter is considered as a root tear. Look at this. This is within 1 centimeter from the insertion. So this tear is called a root tear. Of course, there can be sometimes an avulsion of the meniscus root. This is very common, and usually it is seen in association with some other injuries. This is not a candidate for a root repair or anything like that. What we need to understand here is these root tears are something which we need to identify and treat simultaneously when you have an ACL injury. About 8 to 14% of our ACL tears do come with root injuries. Yeah, done. So they have to be identified and they need to be treated appropriately. There could be various tear patterns, but the treatment of meniscus is not a set pattern. It's a la carte approach. You need to customize your treatment. Partial meniscectomy or a meniscus repair depends on the tear pattern, location of the tear, vascularity, patient factor, weight, return to activity, and the demand of the patient. Thank you.